آه، السلام عليكم. هدول آخر lecture series المايكرو bacteriology course. We will discuss mycoplasma, the other atypical pneumonia causing organism, and then we will have two lectures on mycobacteria. So all in all, these lectures are worth about 3 lectures. بعد هدول الليكتشر سيريز للأسنان بالنسبة للطب بيكون محاضرتين. أم أم بعد هدول المحاضرات بالنسبة للأسنان هذا بيكون نهاية البكتيريولوجي course. And we would have completed almost 26 or 27 lectures um, post mid material. خلينا نبلش نحكي عن mycoplasma pneumonia. هلا المايكوبلازما as we mentioned it causes atypical pneumonia, which is what we mentioned previously as walking pneumonia. So usually is not as severe as bronchopneumonia or lobar pneumonia, but it can progress to severe forms. بالنسبة ل as we mentioned again, walking pneumonia, some people say that walking because the x-ray findings are not typical and they keep going around the lung, either or. What are the important properties of mycoplasma? إذا بتذكروا من بداية الكورس حكينا mycoplasma was the smallest bacteria, and لما حطينا السكيل كانت تقريبة على كتير من بعض أنواع الفيروسز. So it is really small, and mycoplasma is the smallest free-living organism that we have, and really it is very difficult to sometimes extinguish or remove from cell cultures. فمن الأشياء الصعبة علينا is having a mycoplasma infecting cell cultures, especially in research or drug development. The most striking feature is, if you recall, mycoplasma had no cell wall, no peptidoglycan, and had a cell wall that closely resembles that of eukaryotes. So consequently, they do not stain. One of the organisms that stains poorly with the gram stain, does not really stain with the gram stain. And antibiotics that inhibit cell wall, same means they peptidoglycan, beta lactams, penicillins, هذول كلهم, those that target the cell wall will not be effective against mycoplasma. So they have, if you recall, a flexible outer membrane, and they can have a variety of shapes. فما عندنا لا coccus ولا bacillus shape, they're really cell shaped. يعني, so it could be as it depends where they are. So they are the only bacteria that contains cholesterol, which is only found in eukaryotic cell membranes, and that's what we mentioned. Its membrane closely resembles that of our membranes. Mycoplasma, it can be grown in the laboratory on artificial media, but they have complex nutritional requirements that include several lipids. And if you recall, Legionella was also difficult to grow. They are slow growers, much like pertussis, and now we see mycoplasma. And then TB to be very slow growing organisms. فمعناته the doubling time تبعهم راح يكون very long. So they grow weekly and require about a week to form a visible colony. So that's very very, يعني مع انهم صغار كمان وغير هيك, they take a very long time to double. So once the colony has formed, this colony has a characteristic shape that is called a fried egg shape, which with the raised center and thinner outer edges, much like this. Okay, so what are the pathogenesis of this bacterium? It is a pathogen only for humans, and it is transmitted by respiratory droplets. So as we mentioned, it causes pneumonia, so it causes pneumonia, and it is only transmitted, much like all the organisms that cause upper respiratory tract infections, they can only be transmitted by respiratory droplets, and usually the pathogen is only for humans. In the lungs, mycoplasma turns into a rod shape, like this is what we mentioned. Its shape depending on where they are. So with the tip, the organism is rod-shaped with an attachment protein that serves as the point of attachment. Okay, so it's like a receptor that binds to the respiratory epithelium, and then without invading the epithelium, it causes necrosis, and then it inhibits the ciliary motion of the epithelium. So hydrogen peroxide production aids in causing this damage. So mycoplasma has only one serotype. Okay, so and it is antigenically distinct from the other species of mycoplasma. During this infection, many extrapulmonary symptoms can be attributed to cold antigens, and this is what we mentioned at the end of the Legionella lecture. We mentioned we want to differentiate Legionella from mycoplasma, and the way that we do this is by cold antigens. So what are cold antigens? So these are autoantibodies that are produced against red cells, brain, lung, and liver cells, and in lower temperature, in the cold, they aggregate more. So, okay, mycoplasma pneumonia, the most frequent cause of pneumonia in young adults, and the most common cause of atypical pneumonia. So if you see atypical pneumonia, you are most likely not looking at Legionella, you are most likely looking at mycoplasma. It has no geographical preference, and it is more in winter time. So a lot of outbreaks in groups with close contacts, such as family, military personnel, college students. So this can happen. You will find that when you do an X-ray for them, you don't have that typical pneumonia picture, and it accounts for about between 5 to 10% of all community-acquired pneumonia. So here, this is what we're looking at. So this is the mycoplasma here, and it looks like a rod. هنا this is the respiratory epithelium. هي السيليا تبعه, right? So here, mycoplasma, this is another mycoplasma, this is another bacterium. So, and this is the attachment protein that is used to attach itself to the epithelium. Okay, what are the clinical findings? What do we see in a patient that is infected by so atypical pneumonia, obviously. So other causes of atypical pneumonia, as we mentioned, Legionella, chlamydia pneumonia, and then there's another chlamydia called chlamydia psittaci, and then Coxiella burnetii, and then you have all the other viruses. So as we mentioned, atypical can mean many things. Some people say because it cannot be isolated on routine media. Some people say because the patient is walking and not very sick, as in a typical case of pneumonia, or the X-ray findings. So whatever it is, it depends on what you are looking at. So it would require special media, as is seen in Legionella, mycoplasma, chlamydia, these are intracellular organisms. So you require a special media to grow it. So it does not resemble pneumococcal infection on clinical findings that we mentioned. Okay, the onset of atypical pneumonia is usually gradual. It's not sudden. Sudden عادة it denotes the symptoms. It denotes typical pneumonia. Why? Because if you recall from the lecture of مثلا pneumococcus, so you have bacteria that is growing. The patient might have a little bit of productive sputum, but then the bacteria overwhelms the patient. على طول بصير عنده fever, بصير عنده cough, بصير عنده discoloration of the sputum, and the picture becomes very sudden in some of these cases. It is not the case for atypical pneumonia. The cough is not productive, much like Legionella. So ما راح يكون عندك تغير لون أو مثلا لون أصفر أو لون أخضر زي ما بنشوف مثلا mucus in the typical pneumonia case. Why? Because عادة you would require a bacterium to destroy مثلا red blood cells, to destroy neutrophils, and then that pigment that is released causes the discoloration of the mucus. So small amounts of whitish عادة non-bloody sputum, much like viruses is the case here. Constitutional symptoms are very pronounced: fever, headache, muscle pain, and malaise. And again, that still points you towards viruses. Constitutional symptoms are very pronounced with these kind of فمعناته صرنا قاعدين بنشوف احنا mycoplasma. It resembles a viral infection quite closely. So chest examination shows very little findings, not correlating with an X-ray finding, and then it will resolve عادة spontaneously in about 2 weeks. So in addition to pneumonia, it can cause also bronchitis. And then here the picture is finished. So now we know that mycoplasma the picture is very closely resembling that of a viral infection. فعشان هيك مثلا sometimes you might want to give an antibiotic to a patient who has symptoms that might be explained as a viral pneumonia, in case you cannot, because بدك أسبوع أنت تعمل culture, so you can't wait for the culture. You might give an antibiotic, and then there are findings that sometimes help in tipping the scale towards an atypical pneumonia rather than a viral infection. So the extrapulmonary manifestations, these include SGS, erythema multiforme. So this is again something that usually happens with viruses, مثلا HSV. Raynaud's phenomena, and this is مثلا تذكروا مثلا بالبرد، هذا عشان تذكروها مثلا cold antigens، واحد ببرد عادة بصير معه هذولا. This is another extrapulmonary manifestation of mycoplasma. If you do not know what Raynaud's phenomena is, you have a well demarcated blanching of the digits عادة, and that is usually due to vascular, other than vasculitis. It's very closely connected to vasculitis, and then the vessels get really sort of a spasm and stops. So this is the blanching is to do the stoppage of arterial supplies to the digits. عادة بس ما تدفي ايده بترجع هاي لحالها, and as we mentioned, is very closely connected to cold antigens and vasculitis. And there are other neurologic manifestations such as Guillain-Barré, حكينا مثلا post Shigella, and then this post mycoplasma is another. So a person with Guillain-Barré might have usually a bout of diarrhea, but they might have a bout of مثلا pneumonia or bronchitis that precipitates Guillain-Barré. So here let's look. So إذا طلع عليهم أسألك ما تطلع تحت، إذا بطلع عليهم هيك لحالهم هيك, which of the two do you might think is normal? Right? So I would say, without looking, I would say that this is normal, and this is probably atypical pneumonia. Why? عادة هدول infiltrations are more widened. This مثلا, do you see these infiltrations? هدول هون مثلا. So this is where the lymphatics are, and then there's more infiltration. طلع هون, this is a normal X-ray. The infiltrations are not as prominent as here, but you can see مثلا هون مثلا the tip of each of the lungs. There's no مثلا pus or مثلا paima or anything like that. Do not have مثلا whitish nodules anywhere. Do not have مثلا an entire lobe not visible due to collection of pus. So it's the same here, but you have more عادة. This is مطلع عليها. This is where I would, in a viral pneumonia, this can also look the same. In a viral pneumonia, تفتح كمان صور, they might also look this here. It looks a bit like that as well. تمام. There's nothing else to say here. Okay. So a pneumococcal pneumonia, good thing I have it here. You can see مثلا consolidation. So loss of this entire lobe is not shown on the X-ray. Diagnosis. Culture takes, as we mentioned, takes about a week. So we only have one in serology. We only have one serotype. So I might as well use serology for diagnostics. And then we add something else. We know we have cold agglutinins, so complement and complement fixation. So I can use that serology for diagnosis. For diagnosis. So cold agglutinin titer of about 101 to 128 or higher indicates recent infection. So you're more likely if بعمل لك cold agglutinin لكم كلكم, all of you or a large majority of you might have previous infection or have titers to it. Cold agglutinins this is what we mentioned, the autoantibodies that react to ORBCs and cause them to agglutinate at low temperature, about 4 degrees, but not at 37. So usually seen in lymphoma and then mycoplasma infection. So, okay, so the test here is mainly has many limitations, right? And there are a lot of high false positives, especially in viral infections, and only about half the patients who have mycoplasma will be positive. So, so the diagnosis of infection can be confirmed by about fourfold or more rise in the antibody titer. So you will have to have a baseline to have a fourfold, so to compare it to. So عادة it's usually not done. This is only in a case where there's مثلا a consequence, or you want to مثلا exclude something else. That's when you want to do this. عادة a lot of them are just given antibiotics and then or spontaneously resolve. Okay, treatment and prevention. The treatment of choice is عادة ماكروليد، اريثرومايسين، ازيثرومايسين. عادة أكثر إشي زيثروماكس، أكثر إشي هذا بيعطوه عنا خاصة إحنا اللي بنعطيه. Here we go, erythromycin, azithromycin. That's what we give. Another one that you can give is doxycycline. As we mentioned, for all these atypicals, doxycycline is a good choice. Levofloxacin, fluoroquinolone is also very effective, so you can give مثلا. Levo is very good in this case. Since the disease usually resolves by itself, antimicrobials shorten the disease course, and as we mentioned, anything that targets the peptidoglycan layer will not work, and there is no vaccine. Okay, so now let us start the two lectures about TB, mycobacteria. So what are those? As we mentioned previously, we said this is the acid-fast bacilli that have a very special cell wall that resists decolorization, the acid. So they are fast against the acid, and they resist decolorization, and they are aerobes. And the other thing that we know about them is that they are slow growers. So they are neither gram positive nor gram negative because of their special cell wall. They are stained poorly by the dyes of either. They are the only bacteria that are acid fast. الثاني عادة is nocardia. If you remember from the previous in the gram negatives حكينا عن بالانتركس كان عندنا picture. We mentioned how nocardia is another one that can be acid fast as well. So we said acid fast means that they resist decolorization of the red dye, and this is due to the high lipid content of their cell wall. So this is what they look like on your typical acid fast stain. These are rods, long rods that resist decolorization, and they retain the carbofuchsin dye. And عادة they are seen on a blue background. Because they are slow growers, it is very likely لما تحط in a sample that you miss this. This is atypical. This is not very typical to find all these rods next to each other. عادة you can find 1 or 2 or 3 next to each other. So to improve this, we use fluorescent microscopy, where we use an antibody that fluoresces once it is bound to the rod, and then against a very black background. So everything will be black, and then you look through the power fields, and then you can find if you can see like a yellow color usually. So that is very, very easily picked up, so you do not miss it. But this is the older stain that is usually still being used, is the acid fast stain or the Nielsen stain. The major human pathogen in this family, human Mycobacterium tuberculosis, and then the other one is Mycobacterium leprae, which causes leprosy. So each has its disease in its name. Atypical mycobacterium such as Mycobacterium avium intracellular and Mycobacterium kansasi both can cause tuberculosis-like disease but are not as frequent as tuberculosis. Um, so organisms, here let's look at our nice table here. So tuberculosis and avium intracellular both have the lungs as the site of infection. If we do the skin test, which one do we have a skin test for? Is the tuberculosis. It does not work on the avium intracellular. So on your typical TB, you have a skin test and you have a vaccine. Leprosy, obviously, is in the skin and nerves. And the only thing that they all share in common is that they all have multiple drug therapy used. You cannot use a single drug for any mycobacterium. You need a multiple drug therapy approach. So let us look here. So Mycobacterium tuberculosis is your typical one. Leprae is the other one. Atypical one, the ones that we mentioned, also can cause disease. And then you have the avium intracellular complex, as we call that. And then they have marinum that can cause skin infections. Okay, so the other one that is really rare that is usually rapid grower is called Foricium culonae complex. But that's all we just want to know about it. But what we want to cover and focus on are these four, and then this avium intracellular complex. So if you look at it, growth on medium, all of them take weeks, except for leprae, it does not grow on bacteriological medium. So they are all very slow growers. Those that cause lung infection are usually, or مثلا gastrointestinal infection in the case of Mycobacterium bovis, they grow on your typical temperature, about 37. Leprae, the one that does not grow on bacteriological medium, the one that is in the skin, has a lower degree for growth, which is about 32. Marinum can cause okay, so let's just stay here. And then you have this one is also slow grower and 37 degree. What are the sources or the transmission? Now, tuberculosis is this is a respiratory disease and causes, much like all the other respiratory diseases, you get it from respiratory droplets. Bovis from bovine, from cow, so you get it from milk and infected animals. So it usually causes gastrointestinal symptoms. Skin contact. So you have to have a prolonged skin contact. Atypical mycobacteria, many of them are here. These are the atypical ones. So soil, usually through soil and water, especially marinum and avium intracellular complex, usually cause skin infections, can also cause infection in other tissues as well. So let's talk about TB, Mycobacterium tuberculosis. So this is the disease that causes tuberculosis, أو يسمى مرض السل. Worldwide, TB causes more death than any other microbial agent. TB still is is a leading cause of death worldwide. Approximately about a third of the world's population has this organism, and each year about 1.5 to 1.7 million people die of TB, and about new cases occur. You can think of TB as sometimes I think of it as an infectious cancer. So it causes a granuloma that stays in the lung and grows over time, and then starts to invade vessels and cause cough, and then blood comes out, and the patient starts losing weight, and so on and so forth. كل هذا, to me, it resembles sort of a cancer, right? So, and it is a slow grower, and then it causes a large amount of death. So, to me, mycobacterium, this is how I usually describe it, as an infectious cancer. About 500 million of those 9 million new cases are infected عادة with a multi-drug resistant strain of TB. Even with a multi-drug regimen, it is still resistant. Now we will mention why that happens. This is usually in the properties. Okay, so let's see the properties. So MTB is a slow grower, so it has about a doubling time of about 18 hours. So you take a whole day for one cell to become two. So just look, if you take a sample, and they are already so slow growers, so if you take a sample from the sputum, it's most likely not going to have more than a few, maybe tens or more of the organism. So it would take at least 2 weeks to grow a sample. Usually it is held for 8 weeks, about 2 months, before you can record the specimen as negative, and as the earliest possible, before you can get any, if you have captured a large amount of cells, which is not typical from the sputum sample, the most likely and the least amount is about 2 to 3 weeks before you can see any bacteria. And like we mentioned, عادة it would take about 4 weeks, 3 weeks, 4 weeks. That's the typical time before you can usually see it and make a diagnosis. We mentioned TB is culturable on media, Lipri is not. The special media that you know from your lab is the Lowenstein-Jensen medium, which contains lots of nutrients like egg yolk, dyes, the malachite green, which inhibits the growth of normal flora, and then that improves the yield of your specimen. MTB is an obligate aerobe, and much less and likes oxygenated areas, so the upper lobe of the lung and maybe the kidneys as well. One factor is called the cord factor. Cord factor is very strongly linked to tuberculosis virulence. ففكروا فيها cord يعني سلك. Okay, and سلك شكله زي مثل الحية. So that's how you can keep it straight, saying like the cord factor is linked to virulence, and the organisms that has this factor usually cause a more severe disease. So it's present in these virulent strains and causes the organism to grow in a cord-like fashion, a serpent, a cord-like pattern. If you recall from, I think in your lab, and we mentioned before in the immunology, that there's a skin test, and we mentioned about how you require type 4 hypersensitivity, you require cell-mediated immunity because of the growth, the way that this organism grows, to destroy it. So PPD skin test is used to detect previous infection. So similar to other, like the penicillin or anything else. So the PPD skin test relies on, well, not like penicillin, but it relies on the type 4 hypersensitivity to elicit a skin response. So maybe like if you're sensitive to oil or something, certain oils can also be type 4 hypersensitivity. A lipid is located on the bacterial cell wall called thiocerol cosirosate, which is required for the pathogenesis in the lung. Okay, we don't want to memorize it, but just know that require a special lipid in the cell wall for growth in the lung. So MTB is a resistant organism to many outside elements due to the unique cell wall, and as such, elements such as acid or alkali, since this is resistant to them, عادة أنا بحط NaOH in the clinical specimen. In addition to the malachite green, adding NaOH, this strong alkali, can destroy other مثلا human cells, other bacteria, mucus, and then since this organism is resistant to this alkali, it will resist, it will revive, it will continue to survive afwan, and this way you can improve the yield of your specimen. MTB is also resistant to dehydration and remains viable in dried expectorate sputum. So مثلا بحكي لك الناس اللي مثلا they spit in the street, right? And if they have TB, that spit on the street can transmit the disease. If somebody steps on it and then they somehow their shoe goes into their house and then so on so on. So you might be able to get this resistant. So يعني this organism that is closely has some resemblance to even spores in how resistant it is to outside stimuli, acids, alkali, dehydration, right? So this is the cord factor, acid fast stain of mycobacterium. This is a cord growth, serpentine or arrangements. This is a hayaya. So that's the way that these organisms grow for these virulent strains. Strains of NTB resistant to the main antimicrobial drug isoniazid, as well as strains of resistant multiple antibiotics, which are called multi-drug resistant, have become a worldwide problem. This resistance is due to genomic DNA mutations, its own mutation, which as this organism does not contain plasmid DNA. So if you do not kill it, it will continue to grow and it becomes the major infector. So it's not a horizontal, it is a vertical mode of transmission of this resistance. Okay, transmission and epidemiology. Tuberculosis as a respiratory organism, it is transmitted from person to person, as we know, by respiratory droplets. So that's how it reaches the lung. Once it is inside, it is mainly an intracellular organism, and this is why you require a type 4 hypersensitivity reaction to kill it. So with a predilection to reticuloendothelial cells such as macrophages, so they can live inside macrophages. And humans are the natural reservoir. Most transmission is attributed to people coughing on each other, okay? So respiratory droplets, and then those who have a detectable bacterium in the sputum are more infectious. Some people have the infection, they have TB, but it is what is called quiescent, or it is dormant, so it has not broken through to the lung airways, or whatever broke through has already been cleared. So when that patient or person coughs, he does not have any detectable bacterium in his sputum and will not transmit the disease. But those that have the bacterium detectable in their sputum will be transmitting the disease. So this, as we just mentioned, this has broken through and reached the sputum. About 20% of people are infected by a cough aerosol from a smear negative person, so 80% by a smear positive person. So in developed countries, it is a human illness. However, some species of mycobacterium like bovis can cause, as I just mentioned before, gastrointestinal tuberculosis, especially in non-pasteurized cow milk. The risk of infection of disease is highest amongst socioeconomical disadvantaged people with poor housing and poor nutrition. فمثلا كانت الدول الغربية, Western countries had a huge problem with TB in the 1800s, when there were a lot of people living in close proximities in a very lots of them are poor sanitation, poor housing, poor nutrition, poor heating, so they're all next to each other, and TB was a huge big problem in the West. As the West advanced and they had better housing, better nutrition, better heating, better everything, it started phasing out of these countries, and now it is mainly a problem of other countries where you have a lot of poor housing, poor nutrition, so lots of Asian countries and some African countries as well. Okay, so where were we? Okay, so we were talking about in bovis and how Mycobacterium bovis and how it can cause gastrointestinal tuberculosis in humans in unpasteurized milk. And we talked about the poor housing and poor sanitation in the West and how that was transmitted to the East in Asia and some African countries. Okay, so the pathogenesis of tuberculosis, it produces no exotoxins, ما عندها exotoxins. Does it have an endotoxin in its cell wall? No, it does not. It is not a gram-negative, so it will not produce that. Mycobacteria produces no toxins, so it infects and resides within macrophages, زي ما حكينا, and other REC cells, reticular endothelial cells. هلا Mycobacterium tuberculosis survives and multiplies within a cellular vacuole called a phagosome, وهو بتعرفوه phagosome, as the phagocyte takes up this bacterium. This bacterium, who TB, it escapes being destroyed by making what is called exported repetitive protein, which prevents the phagosome from fusing with the lysosome. هذا إشي حكيناه قبل هيك أكثر من مرة. هلا if the phagosome does not fuse بالسيتوسكيلتون، ضله ماشي على السيتوسكيلتون زي القطار، بده يركب لما يوصل لللايسوسوم يتحدوا مع بعض وينزل اللايسوسوم يكسر البكتيريا. هاي البكتيريا بتطلع هذا ال ERP, exported repetitive protein, which prevents this train from colliding with the lysosome, and then which have the destructive enzyme. أنا يعني رأيي إنه this qualifies as a toxin. This is an exotoxin بالنسبة لي because it modulates something outside the cell, but it is not a true exotoxin in the fashion زي ما حكينا بقية الexotoxins. بس إذا بتتذكروا حكينا one of the exotoxins was preventing G proteins, which are the cytoskeletal elements, from doing their function. So يعني هاي بيجي بين هون وهون. But for exam purposes احنا خلينا نحكي إنه there are no exotoxins for MTB. Lesions are dependent on the presence of the organism and the host response. شو يعني? We know that it produces granulomas. شو هم الجرانيولوماز؟ You know from pathology إنه عبارة عن central area of giant cells containing these tubercles, and then they are surrounded by a zone of epithelioid cells, histiocytes, أهم خلية, and then they keep building and building around these giant cells, which are Langerhans cells, and there you have it. The other one is you have other types of lesions called an exudative lesion, which consists of an acute inflammation response, and then this occurs chiefly in the lungs at the initial site of infection. So at the beginning you have this exudative lesion, and then you have the chronic granulomatous lesion. Now within this granuloma راح تلاقي الخلايا that are within the middle, the core of the granuloma, are more dormant. والخلايا كل ما بعدت could become more and more active. Now the dormant cells behave like a spore, in the manner is that their metabolism is less. So if the metabolism is less, they obviously will be more resistant to drugs. هذا أولا. ثانيا, the granuloma behaves, again, behaves as, it's not a spore. وهون النقطة الثانية, it's not a biofilm, but it behaves like a biofilm in the manner that it prevents the drug from going through all the way to the core of the granuloma, and that is the challenge in treating tuberculosis. Now, these giant cells, حكيناها, a tubercle is a granuloma surrounded by fibrous tissue that has undergone central caseation, and you know this is a caseating granuloma, and then they hereby heal by fibrosis and calcification, and the longer it is, the more calcified it can get. Okay, a spread of the organism within the body occurs by two mechanisms. How does it spread within? So it's erosion, both by erosion. As it gets larger تكبر راح تدخل يعني راح تصادف نفقين. النفق الأول هو الأيروي. If it goes through the airway, this patient becomes more infective and he starts coughing more, and then he has هاي tuberculosis تنزل bacteria into the airway. So the gaseous content are emptied into the airway, and the infected person then swallows these hardly bacilli into the GI, coughs, and spread them through aerosols. الثانية, if it breaks the other, النفق الثاني ممكن تدخل عليه اللي هو blood stream. So if it can gain access to the blood, it can possibly go to many internal organs and would usually happen in the event of if you are unable to contain the early stage of infection. So بالمناسبة أغلب الناس اللي بنعدوا they clear it, يعني أو بدخل هالخلية بكون because الخلية عبارة عن كتير, the bacterium is very slow grower, so most people who encounter it actually clear it. It's the problem is إنه الناس بيكونوا جنب بعض كتير, poor sanitation, poor housing, so the patient gets it more once and twice and 3 times and 4 times until he becomes infected. So that's why in the West مثلا واحد ممكن ياخذها مرة بالوest من واحد تاني, but they're more likely to get over it, and they're more likely or unlikely to come into contact with it again because of the better housing and sanitation. Okay, so immunity and hypersensitivity. After recovery from the primary infection, resistance to the organism is mediated by cellular immunity. Obviously, why? Because this is a intracellular organism. So CD4 positive Th1 cells and macrophages through that type 4 delayed hypersensitivity reaction. Okay. Patients deficient in cellular immunity, مثلا, such as patients with AIDS, راح يكون عندهم CD4 cells صح, are at much higher risk for disseminated life-threatening TB. A mutation in the INF gamma receptor, شو راح يكون عنده interferon, will hinder macrophage activation and predispose to obviously severe TB, this is another intercellular, as you know, this is a cellular immunity mechanism. Okay, so prior to infection, infection can be detected by positive tuberculin skin test, PPD بسموه purified protein derivative, is the antigen used for this test and comes in many strengths, and the medium strength one usually used first. The test is then ايش بيعملوه زي بيشبه التست تبع وجدتكم اياه تبع البنسلين. It is applied in the dermis and then observed over a few days. تبع البنسلين تبع كان شو, not few days, over hours بالكتير, it's minutes, because that one is a type 1 hypersensitivity, this is a type 4 hypersensitivity, so you observe it over a few days. بتخلي and you wait for, what do you look for? You look for skin induration, thickening, and not only redness, which is what you look for, erythema, because of histamine هذا بتطلع عليه بالبنسلين in the type 1 hypersensitivity. This one is not. So the induration is then measured by a special ruler, which what we look at, هاي الانduration بتطلع عليه على حجمه. And this is where you injected this protein. So the protein derivative of the PPD is injected, and then days after you measure this with a ruler. Another one here. So to judge the test, شو بطلع if the person has no known risk factors, ما عنده أي risk factors, he has good immunity, he is young, ما عنده مشاكل, ما عنده أمراض, nothing, right? If it's this healthy individual, 15 millimeter induration or more is positive. Anything less would be deemed not positive. Why? Because that patient would mount a quick response and the immune cells would cause an induration invariably. Now, if this patient is a patient with high risk factors, مثلا a person who is in a poor housing and sanitation, as a homeless person, or a patient in a nursing home resident, هذول كلهم كبار بالعمر عايشين بنفس البيت مع بعض، يكون مش بيت، يعني nursing home زي دور العجزة، هذه كتير موجودة كتير بالغرب. So هذول مثلا صار فيهم كتير عندهم كوفيد و deaths, lots of deaths in these nursing home. هلا هذول من أول الناس قاعدين بيعطوهم الفاكسين. So IV drug abusers, these are high risk groups, right? So here in this case, if someone has a larger induration that is smaller, about 10 millimeter, this is considered positive. Someone with no immunity, you do not expect them to have any induration with the PPD. If they are infected, they will form something that is 5 millimeter or more, will be deemed positive. Okay, so a positive PPD test only indicates previous infection, does not mean an active disease, right? Okay. So this takes about 4 to 6 weeks to have a positive PPD test after infection. تمام. There's a vaccine اسمه BCG vaccine, Bacillus calmette-guerin vaccine, which can cause a positive test. This is the vaccine for TB. هذا الفاكسين بيعمل عند الناس cellular immunity against the bacillus, uh, but it's not very effective. Effectivity تبعته تقريبا من 0 ل 50%. So جيلي أغلب الناس أخذوها. If you can look at your arm, if you have this induration on your arm, that means you're one of the people who got the BCG vaccine. هلا مش قاعدين بعطوه للكل, it depends. So if you have taken the BCG vaccine, you're likely to make an induration with have a positive PPD test. Findings. What are the clinical findings? Okay. So many organs can be involved. فبتشبه حكينا بتشبه زي كأنه واحد معاه an infective cancer, right? So you will have fatigue, you will have weight loss, you will have تكون تعبان وبنزل وزنه. But the infective part is the fever. You will not have that with cancer. ثانية is you will have night sweats. This is يعني a classic symptom that is used in tests to say إنه عشان توجهك إنه تحكي هذا TB أكتر. So fever with night sweats, weight loss. This is not. This is more likely TB. Pulmonary شو راح يكون عنده cough and hemoptysis. هذه كتير يعني this means إنه صار في breakage, صار في زي ما حكينا invasion into surrounding vessels. If it goes through the lymphatics, it will make lymphadenitis, which will make a large neck swelling, بسموها scrofula. ما بعرف إذا عملنا هيها. So this is a scrofula in a patient with active TB. Okay, this is the most common extrapulmonary manifestation of TB. Erythema nodosum, this is it. So erythema nodosum is this erythematous nodules, usually on the anterior part of the lower leg and the shins. erythema nodosum تعرفوا إنه مش بس بالتي بي, مثلا كتير في autoimmune diseases you will have erythema nodosum, especially مثلا شو بسموه sarcoidosis, autoinflammatory disease. Other things you can have erythema nodosum, but one of them is also TB. Okay, so tender nodules along the extensor surfaces of the tibia and the ulna. Manifestation of primary infection seen in patients who are controlling the infection with a potent cell-mediated response. That tells you, a patient who forms erythema nodosum is making an adequate cellular response against the TB and more likely to have a better outcome. Patients with HIV are more likely to have multifocal lymphadenitis than those not infected with HIV. Can disseminate to bone or meninges. Gastrointestinal TB, abdominal pain and diarrhea with general symptoms such as fever and weight loss. Intestinal obstruction or hemorrhage may occur. خاصة ileocecal region. You know that the cecum, between the ileum and the cecum, is the narrowest lesion. So this is a patient where an area where the obstruction may happen. GI TB is caused by the expectorant from the lung and is swallowed, or by imbovis when it is ingested in unpasteurized milk. Tamam, it can occur in the oropharynx as a painless ulcer with local adenopathy. Renal TB, dysuria, hematuria, flank pain, right? So nothing that tells you it's TB. This is just infection. Dysuria, infection. Flank pain, anything flank pain. مثلا renal stone can give you flank pain. Pyelonephritis can give you flank pain. Kidney disease, any kidney disease can give you flank pain. Hematuria, stones can give you hematuria. So they're not really. But then sterile pyuria, this is a characteristic finding, which means ما فيش bugs, you don't see, but there's a lot of white blood cells. That is more likely to be TB. So the urine contains white blood cells, but the culture of the common urinary tract pathogens, مثلا تعملوا Klebsiella ولا E. coli or Enterococcus or whatever, راح يطلعوا كلهم negative. فهنا you are directed more towards renal TB. However, mycobacterial cultures are often positive, obviously. إذا تعملوا بدك تستنى عليها أسبوعين 3 لما يطلعوا. ممكن يطلع positive, but you have to put it on the adequate Lowenstein Jensen medium مثلا. 90% of infections with MTB are asymptomatic, latent infections. فهذول أغلبهم حكيت لكم من قبل. These are people with infection. The majority of people clear the bacteria and never get infection. Those who get infection, 90% of them have asymptomatic latent infection. These latent infections can reactivate and cause symptomatic tuberculosis at any time. Okay, although there may be some differences in virulence between strains or organisms, the most important determinant whether overt disease is the patient's cell-mediated immunity. فif you happen to make حكينا بذكروا محاضرات الاميونو خاصة بالبداية حكينا if you happen to make a cell-mediated immune response early on, you are more likely to control it. إذا عملت a Th2 response, you're less likely to control it. So it depends on how adequate, on how quick your cell-mediated response has been mounted against this bacteria. In people with low response, طبعا, if untreated TB has about 50% mortality rate. Drugs that affect مثلا tumor necrosis factor, which is مثلا infliximab, have activated latent TB in some people. So this is something. مثلا this is one of your cellular immunity, if you recall from macrophages. So this is one of your defenses. If you give a drug against them, so that may lower your threshold to have the latent TB to become activated because it is not being stopped by TNF anymore. And diabetics have a reduced overall immunity and more likely to have reactivation. So someone who doesn't have diabetes has latent infection, become diabetic, more likely to have a reactivated infection. Diagnosis in the lab. First, we do acid-fast staining of the sputum. هذا أسرع وأسرع شيء. ذكر حكيت لكم fluorescence. Fluorescence هذا مسميها أورامين stain. هاي اللي حكيت لكم عنها صورها أصفر أو on a black background. This is called Auramine stain. Usually, he fluorescent stain that binds the cell wall of this bacterium. After digestion of the specimen by treatment in AOH and other, we put the material in a special media called Lowenstein Jensen media. We know this up to 8 weeks. If it does not grow, we say it is wrong. Oh, there's no growth after about 8 weeks. No growth on blood anchor will happen. Okay. باكتك ميديوم هذا نوع من انواع الميديوم نستخدمه بنحط بجهاز هيو بنحط هذا هو الباكتك ميديوم بتحط هي شايفين هون الخطوط they streak the specimen on it and they keep it inside بيسجلها مثلا على الجهاز انه رقمها كذا كذا هذا المريض رقم هي عينته بحطها and it keeps growing for weeks they leave it there إذا صار فيها growth بزيد فيها نسبة ال CO2 بيحكي لك الجهاز أن نسبة CO2 زادت بهاي الميديوم this is positive come check it so you take it and you do Auramine stain on it whatever you visualize it and then you diagnose it هذا الأورامين stain you can see the bacilli fluoresce and this is all black because this is how fluorescent microscopy works and this is the ZN stain شو ضل هون ما حكينا after you grow it, you can do biochemical test on it. MTB produces niacin, where almost no other mycobacteria do. Also produces catalase. Okay. PCR test. PCR شو بده؟ بده DNA. And if this bacteria is a slow grower, that means you are less likely to capture DNA early on in the infection, and more likely as the infection becomes more active, more likely to capture it. So PCR is a good test as long as you are able to get the specimen that has the bacterium and then you are able to destroy the bacterium عشان يطلع الDNA عشان انت التست تبعك يشتغل. So this is the amplification of the gene using obviously PCR. Tests are available to detect either the RNA or the DNA of the organism. These tests are highly specific. So you do first the sensitive test فأنت تعمل sensitive test to capture as many as you can. So عادة هي هيك بتكون tests are done. So you do a sensitive test first, and all the sensitives or the positives here are more likely to be positives. فبكون عندها بيسموها SNOUT SNOIOT. So sensitivity rules out. So if it's a highly sensitive test, it rules out the disease for you. فاللي بيكون عنده بيطلع مع positive, it's probably true positive بيكون عنده منيح. you go, if it's negative, it's more likely a true negative. this is sensitivity بيكون مثلا true, negativity بيكون فيها منيحة عالية. and then you do a specific test where it's مثلا يكون عندها high true negative. A good specific test is PCR. So the sensitivity of PCR tests are higher in smears, in smear positive people. Why? Because you are going to capture more bacteria. Okay, because drug resistance is a significant problem with mycobacterium, we need to rely on sensitivity testing to give the correct antibiotic regimen. So we do need to grow it. عشان هيك انت ما تعمل بس PCR تحكي عنده PCR هيو positive يلا روح عالجه. We still need to grow the organism. So since cultures take weeks, نحن نعمل ال PCR بداية, and then we can change our drug regimen later on. مثلا catalase gene mediates resistance to isoniazid. ممكن مثلا ندور على, ممكن نستخدم PCR ندور على certain genes within the bacterium genome, and then بحكي لنا هدول الجينات do they have resistance. So you can get sort of a small resistance pattern من ال PCR. مثلا بدور على catalase gene بحكي لك انه عنده resistance to isoniazid. RNA polymerase gene مثلا عنده resistance to rifampin. تذكروا محاضرة antimicrobials. Another useful test مثلا resistance to is the luciferase acid. So we can do a few tests so you can see direct your early drug regimen. تمام. We can grow the organism with each drug we need to test, and then we add luciferase. مثلا luciferase gives you flashes of light, so if the bacterium is able to grow, it will use the ATP and then will show these flashes of light. That tells you it is able to live around this drug and it is resistant to that drug. Okay, diagnosing latent infection. تعملوا PPD test, lab assays مثلا. Lab tests have equal sensitivity and specificity to PPD مثلا quantiferon TB or the T-spot TB. What is the basic principle of these? Is that we add your blood to an antigen from MTB and we measure how much interferon is released, is how much previous memory do you have. That tells you, this is the principle of these two tests. تمام. Treatment من محاضرة الانتيميكروبيالز. Anti-TB treatments. We know that this is كل drugs حكيناهم, we almost use most of them in each regimen. بما إنه هذا a very slow grower, فمعناته it is very slow dyer, يعني it dies very slowly, as we mentioned in the growth lecture, right? So as you grow slowly, you are dying slowly, you are using metabolites slower and everything. So to circumvent this problem, because of it is a slow grower, it is able to take its time dealing with antimicrobials, so it is more likely to become resistant as it is growing. So to stop this, it's less likely that you make if you hit a bacteria with 2 or more antimicrobials, it is very unlikely that this bacterium will, حضرت genetics, it is very unlikely that this bacterium will produce will produce 2 spontaneous mutations for 2 different drugs at the same time. فإحنا بنستخدم مثلا ممكن 3 drugs or 4 drugs, right? So this reduces the multi-drug resistance. So isoniazid, it's a bactericidal, is the mainstay of treatment. It is included in almost every regimen. So for pulmonary TB, بتستخدم isoniazid, rifampin, pyrazinamide with or without ethambutol. Isoniazid and rifampin are given for 6 months, but pyrazinamide treatment is stopped after the first 2 months. So we give all drugs for 4 months, isoniazid, rifampin, pyrazinamide, ethambutol, and then we were 4x2, and then 2x4. For the next 4 months, we only give 2 isoniazid and rifampin. If the patient is immunocompromised or have disseminated disease, who are likely to have isoniazid resistant organisms. All 4 drugs are given for about a year, 9 to 12 months. Once therapy is started, patient becomes smear negative, non-infectious in about 2 to 3 weeks. The long therapy is due to the nature of the disease, which hinders the reach of the drug. حكينا it's a caseous material, it's in a granuloma, it is intracellular, it's a slow grower. It is these persisters اللي حكيت لكم عنهم, these more dormant within the lesion are persisters. Patient non-compliance, كل هذا أشياء بتأثر على التريتمنت and why the long therapy is used. There's a new drug in 2013 called bedaquiline, which was approved for the treatment of these multi-drug resistant strain. It should be used in combination with other drugs, not as a monotherapy, obviously. It is a diaryquinoline, which inhibits the ATP synthesis, unique to MTB. Prevention. Since the 1940s, risk factors was reduced over time who better living conditions. زي مثلا cholera, the best prevention is to give people clean drinking water and sanitation. In here, risk factors are the housing conditions. So incidence began to decrease as housing conditions improved after the Second World War. At present, prevention for the spread of organism depends largely on the prompt identification and treatment of patients who are coughing, who are sputum positive. Can use masks and other respiratory isolation procedures in areas مثلا إذا كان في كتير ناس. Contact tracing زي ما بنعمل هلا بالكوفيد. So if you look at this map, وين المناطق اللي فيها كتير, now the countries, usually the Western countries have control have the بهالوقت من الزمان Western countries have better housing, usually better housing, better economies, so they have the least incidence. So هاي الماب عبارة عن housing and living standard map because it correlates with TB. As living standards become worse, مثلا Asia, China, India, so في كتير ناس, مع إنه الصين مش دولة غنية, لكن في عندهم كتير فقراء وناس كتير, عددها هائل من الناس. The Indian subcontinent, هذا مش accurate, it's because it's Russia, so it's in this area, but this is all usually uninhabited. And we said sub-Saharan Africa and some areas of South America. These are the highest hit. احنا منطقتنا is the يعني بتيجي الدرجة الأعلى أو الدرجة الثانية بعد Western countries. This is our area, alongside with Mexico, and I think this is Argentina. Okay. What else? And then you have the highest in about South Africa. This is the hardest hit countries. PBD testing or available quantiferon TB or to detect latent infection and to screen at-risk people. This is important, especially people who are at risk. BCG vaccine, it provides partial resistance to tuberculosis. The patient can still get infected, but more likely to have a better outcome. So it contains a live attenuated strain of Mycobacterium bovis, which prevents the emergence of the clinical disease, but it has a variable effectiveness. BCG vaccine. تمام. So BCG vaccine is also used to treat bladder cancer. So this is an interesting tidbit that people who have the BCG vaccine were shown to have better outcomes of bladder cancer. So not the BCG vaccine, الناس who have bladder cancer, that type of cellular immunity seems to destroy these cancer cells, only for bladder cancer though. So the vaccine is instilled into the bladder cells and then serves to non-specifically stimulate cell-mediated immunity, which inhibits the growth of carcinoma cells. Pasteurization of milk and destruction of infected cattle are important in preventing the GI TB. هلا بالنسبة للمايكوبacterium leprae, this is an organism that causes leprosy, اللي هو مرض الجذام. So let me أوريكم صورة. هذا هو صورة الجذام. So this is leprosy. So where were we? Okay, so important properties of M. leprae has not been ذكر. حكينا it does not grow in culture media and grows at lower temperatures than the regular TB. It can be grown in experimental animals such as mice, مثلا armadillos, تمام. And this seems to be armadillo. تشوفوه هذا كتير in Texas. يعني إذا بتفتح جوجل بتعرف كيف شكله. So these seem to have some sort of reservoir for human infection in that area. تمام. So in this leprosy can be thought of as a zoonotic disease. يعني zoonotic disease بيجي من animals, not like مثلا TB which comes from respiratory droplets from human to human. The optimal temperature for growth is lower than the body, so it's about 32, which is the skin and superficial nerves. So it's very important, nerves and skin cells. Grows very slowly, doubling time about 14 days. This is so slow. So that's why the symptoms are so slow that a patient who has leprosy might not feel it for 10 years. حتى لما واحد يحكي له واحد شافه قبل 10 سنين يحكي له يا زلمة أنت شكلك مختلف شو صار فيك؟ That might be the instigator why someone might think they have TB. عفوا, leprosy. One consequence of this is that antibiotic therapy must be continued for a long time, usually for several years, to stop the disease. It will not reverse the damage. Longer doubling time means longer antibiotic treatment. Transmission. This is a skin problem, so you have to have a prolonged contact with that patient with lepromatous leprosy who discharged in that area. In the US, leprosy عادة أكثر حكينا Texas, Louisiana, California, Hawaii. So for them it's the south. For us موجودة عندنا إحنا خاصة بالمناطق الصحراوية. Most cases are found in immigrants from these Asian countries and the Philippines. It occurs worldwide in the tropical areas. Pathogenesis, the organism replicates intracellularly just like others, typically within skin cells, histiocytes, endothelial cells, and the Schwann cells, myelin for the peripheral nerves. So this is the Schwann cells. The nerve damage in leprosy is the result of two processes: damage caused by direct contact with the bacterium and damage caused by CMI attack on the nerves. There are two different forms of leprosy, some tuberculoid and lepromatous leprosy. Several intermediate forms between the two extremes. So between these two forms of leprosy, the tuberculoid makes one or few lesions with little tissue destruction. The lepromatous, يعني الجذامي, has many lesions with marked tissue destruction. So this is more damaging to the cells. The number راح يكون هنا أعلى بالخلايا بكتيريا، هون راح يكون أقل. likelihood of transmitting طبعا راح يكون هذا كل ما زاد عدد الخلايا راح يكون أكثر، وهذا راح يكون أقل. Cell-mediated response to leprosy. If you have a good response, you will form the tuberculoid leprosy. If you do not have a good adequate cell-mediated response, that person will have a lepromatous appearance, which obviously a person will have reduced or absent cell-mediated response to this organism. إذا تعمل له skin test called lepromine skin test, this patient will be positive because he has cell-mediated response. This patient will be negative, which because he does not have the cell-mediated response. Okay, so tuberculoid بسموها مثلا paucibacillary leprosy. The cell-mediated response is present, few bacilli are there, granulomas are less, كله هذا حكينا موجود. So there's nothing really that would mention CD4 response, Th1 cells, تمام. The lepromine skin test is positive in this case. Why? Because of the cell-mediated response formed here. Lepromatous, the multibacillary leprosy, حكينا the cell-mediated response will be less. That's all we need to know here really. So if you make a Th2 response, more likely to make a lepromatous appearance of this disease. Clinical findings: the incubation period averages about several years. The onset of the disease is very gradual. The tuberculoid راح يكون عنده hypopigmented macular plaque-like skin lesions زي هيك. شفتهم عند مريض قبل كم من يوم. شفت الصورة. Patient will start having lots of these, and it is very hard to detect if they are leprosy or the early lesion of leprosy. تمام. Leprosy, multiple nodule skin lesions occur, resulting in these typical lion-like faces. هذا وجهكم إياه. After the onset of therapy, patients with leprotomous leprosy, they usually they have the erythema nodosum, which means إنه صار عندهم cell-mediated immunity is being restored. So erythema nodosum is characterized by painful nodule. حكيناها هذه. Okay. هاي leonine faces أو الوجه الأسد مثلا. The face resembles a lion with a prominent brow. This is the areas. كل ما هاي الاريا أخف فيها درجة حرارة هي المناطق اللي بنمو فيها البكتيريا. So the disfigurance appearance of the disease results from several factors. The skin anesthesia results in burns and other trauma which the patient does not feel. Resorption of bone also leads to loss of features such as the nose and the fingertip, and infiltration of the skin and nerves leads to thickening and folding of the skin. In most of these patients, the disease resolves spontaneously. Some people will form this disease in intermittent periods and they become worse over the years. Diagnosis: ما عندك skin test، بدك تاخذ شو؟ بدك you have to take these bacilli and it's very easy to show them on an acid fat stain. فبتعمل مثلا ZN stain. You can do some histopathology as well. You can see these foam cells, خلايا macrophages that have these many bacilli and these many lipid laden granules. The tuberculous form, you have few organisms are seen, and this is seen in the granulomas. You have to take it from an actual granuloma to capture these bacilli. Cultures are negative because the organism does not grow. حكيناها on a culture. Serology for IgM of this lipid, glycolipid 1, is useful in diagnosis of the dermatitis type. Treatment: هذا دابسون يعني بجزء هو من أقل من هي المكان الوحيد راح تسمع عن دابسون أو إذا مكان تاني بس هنا دابسون is the mainstay therapy ل leprosy. But because sufficient resistance to this drug has emerged, combination with other مثلا دابسون مع rifampin or clovasamine as well. Treatment is given at least for 2 years and until the lesions are free of organisms. Prevention: isolation of these patients coupled with chemoprophylaxis for exposed children especially is important, and there is no vaccine. ويعطيكم ألف عافية.